Hello, my name is Babette Langeneckert. I'm a Senior Data Coordinator at the Missouri Cancer Registry and Research Center. This presentation slides were created by Lucinda Ham, Senior Health Program Specialist. This presentation will cover the hematopoietic neoplasms. Our objectives will be to review basic hematopoietic terminology, hematopoietic cell types and transformation, assigning primary site, and we'll go over the hematopoietic database, diagnostic confirmation, the hematopoietic coding manual, and the multiple primary roles. And we'll go over some specific histology scenarios and the multiple primaries calculator, myelodysplastic syndrome and myeloproliferative neoplasms, Hodgkin lymphoma and non-Hodgkin lymphoma, and finally, post-transplant lymphoproliferative disease. This is a list of prefixes and suffixes related to hematopoietic neoplasms. A prefix is a word part added to the beginning of a word. Eosino means red. Hemato means blood. Leuco is white. Mono is single. Thrombo is clot. Veno is vein. A suffix is a word part added to the end of a word. Blast means immature cell. Cytosis is an abnormal condition of cells. Globin is protein. Megaly means enlarged. Pinia is an abnormal reduction in number. Phage is eat or swallow. And stasis means stop or controlling. Now we will review the hematopoietic cell types. This table shows the hematopoietic cell types and their functions. Red blood cells, or erythrocytes, are made in the bone marrow and found in the peripheral blood. They contain hemoglobin, or protein. They transport oxygen from the lungs throughout the body. White blood cells are leukocytes made in the bone marrow and are found in the blood and lymph tissue. They are part of the immune system and help fight infection. The types are granulocytes. These are neutrophils, eosinophils, and basophils. Monocytes and lymphocytes are B cells and T cells. Plasma cells are plasmacytes developed from activated B cells, a type of white blood cell, and they make large amounts of a specific antibody. Platelets, or thrombocytes, are formed by breaking off a large cell in the bone marrow and are found in the peripheral blood and spleen. These form blood clots, slow and stop bleeding, and helps wounds heal. There are three types of lymphocytes. T lymphocytes are a type of white blood cell that directly fights foreign invaders, also called a T cell. They produce cytokines that help activate the immune system. T lymphocytes develop from stem cells in the bone marrow and mature in the thymus. B lymphocytes are a type of white blood cell that makes antibodies. They are also called a B cell. They are part of the immune system. B lymphocytes develop from stem cells in the bone marrow to circulate in the blood. NK, or natural killer lymphocytes, are a type of granulocytic immune cell with enzymes. They kill tumor cells and virus-infected cells. NK lymphocytes develop and mature in the bone marrow and can be present in extranodal tissue. This is a picture of the lymphatic system. As you can see, tonsils, adenoids, thymus, spleen, lymph nodes, and lymphatic ducts are all part of the lymphatic system. Transformations. Certain hematopoietic neoplasms can transform to a more serious or acute histology. Do not be fooled by chronic or acute in certain histology names. The use of these terms can refer to the indolence versus aggressiveness of the cancer. Look at the Hematopoietic Database Manual under Transforms from and Transforms to for histologies that can transform. Some acute neoplasms can become chronic over time. Chronic cells may not transform all at once. Be sure to review the appropriate timing rules to determine the number of primary tumors. This is a diagram of hematopoietic cell division. Hematopoietic stem cells are the stem cells that give rise to other blood cells. This process is called hematopoiesis. Hematopoietic stem cells give rise to different types of blood cells in lines called myeloid and lymphoid. Now we will review coding tips for assigning primary site. Look up the histology code in the hematopoietic database to determine the primary site if you're unfamiliar with the code. Make sure the histology is reportable based on the hematopoietic database. Check imaging studies for clarification. Histology code should be based on the path report. Don't worry about genetic or immune phenotyping. Code primary site according to the physician or pathologist statement. Blood draw and bone marrow biopsies code to C42.1. Lymph node biopsy of a hard, palpable node code to C77.0 to C77.9. Assigning the primary site. Use the primary site coding instructions in the primary histology rules and the heme database to code primary site. Note, this does not mean that you can't have an uncommon primary site. Do not simply code the site of a lymph node biopsy. Use the information available from scans to determine the correct primary site. Frequently, with lymphomas, the most convenient location is biopsied to get a diagnosis. This does not mean this is the primary site. For hematopoietic neoplasms, the pathology report is not the default for determining the primary site, especially for lymphoma. The standard for determining primary site differs depending upon the specific histology. So, did they draw blood with a small needle stick in the arm? Code to C42.1. And if they sucked out bone marrow with a giant needle stick in the hip, again, you would code to C42.1. But if they cut out or biopsied a hard, palpable, or shoddy lymph node, you would code primary site to C77.0 to C77.9. Now we will review the hematopoietic database. The hematopoietic database can be found on the NIH Surveillance, Epidemiology, and End Results, or SEER website. After entering the hematopoietic database, you can search by code or histology name. This is the histology information for acute myeloid leukemia. Click on the code description for detailed information, such as the effective date of the codes, what primary site should be assigned, and if the case is reportable. Notice you can also enter the year the patient was diagnosed to get the correct information for that particular year, because coding rules tend to change over time. Scroll down to find more detailed information about acute myeloid leukemia. Abstractor notes have helpful hints for coding, determining grade, and has some staging details. More specific acute myeloid leukemias are listed. Be sure to review and code to the most specific histology. For example, acute myeloid leukemia with maturation should be coded to 9874/3 rather than 9861/3. Additional information about acute myeloid leukemia can be found by scrolling down. Definitive diagnostic methods are bone marrow biopsy, genetic testing, and immunophenotyping. Look for this information in the electronic medical record and path report. You will also see that treatment for acute myeloid leukemia is chemotherapy and hematologic transplant or endocrine procedures. In Transformations 2, you will see acute myeloid leukemia does not transform to any other disease process. But in Transformations From, you will see there are many disease processes that can transform into acute myeloid leukemia. Same primaries suggest alternate names and equivalent histologies. Once again, be sure to code the most specific histology. The corresponding ICD-10 CM code can also be found here. This can be a good reference for case finding. In addition, you will find the most common signs and symptoms of acute myeloid leukemia. There is also a list of potential diagnostic reports that can guide abstractors on where to look for information in the electronic medical record. Now for some acute myeloid leukemia quick facts. The four main types of leukemia are classified by the rate of progression, the acute leukemias grow quickly, and the chronic leukemias progress over time, and the type of blood cell affected, either lymphocytes or myelocytes. The most common age at diagnosis is between 65 and 74. Risk factors include prior chemotherapy or radiation and smoking. 4.2 new cases are diagnosed per 100,000. Death rate is 2.7 per 100,000. The 5-year relative survival is 31.9%. Do not code therapy-related myeloid neoplasm simply because the patient has a history of radiation or chemotherapy. The physician must state neoplasm is therapy-related. Now we will review diagnostic confirmation for hematopoietic neoplasms. Diagnostic confirmation is the most common field miscoded by abstractors. Flow cytometry is frequently done on peripheral blood smears. Flow cytometry is used for immunophenotyping and genetics tests. These are required for a diagnostic confirmation code 3. If the results from the flow cytometry confirm the diagnosis, then code diagnostic confirmation 3. Code 3 should be used if genetic or immunophenotyping studies are performed. Code 3 should also be used if there is a peripheral blood smear followed by flow cytometry. The term consistent with. For hematopoietic neoplasms only, consistent with is a definitive diagnosis and not an ambiguous term. Now we will review the multiple primary rules in the hematopoietic and lymphoid neoplasm coding manual. The most recent version of the manual was published in November 2024. For ease of use, it is best to download the document. Here are some tips for using the multiple primary rules. Assign a provisional histology. While in the heme database, review transformations, abstractor notes, same primary, and Hodgkin versus non-Hodgkin. Start with the rule M1. Move through the rules in order. Stop at the first rule that applies. Use the heme database multiple primaries calculator only when the rules instruct you to do so. Multiple primary rules. Rule M1. Abstract a single primary when minimal information is available, such as a death certificate case or path report only case. Rule M2. Abstract a single primary when there is a single histology. Rule M3. Abstract a single primary when a sarcoma is diagnosed simultaneously during initial clinical workup or after a leukemia of the same lineage, and refer to Appendix B in the manual. Rules M4 to M6 are related to Hodgkin and non-Hodgkin lymphoma. This is an example of Rule M3. A patient was diagnosed in 2023 with acute myeloid leukemia with a specific chromosomal abnormality where chromosomes 6 and 9 swap genetic material at specific locations, leading to a fusion protein called DEK NUP214. The same patient presents in 2024 with a myeloid sarcoma of the orbit. Step 1. Use the hematopoietic database to assign a provisional histology. Review information in the hematopoietic database abstractor notes for both histologies. Step 2. Review multiple primary rules. Find the first rule that applies and stop. Per Rule M3, this is a single primary. The Appendix B table confirms both histologies are of the same lineage. Continuing with the Rule M3 example. Step 1. The provisional histology for acute myeloid leukemia is 9865/3. The histology for myeloid sarcoma is 9930/3. The abstractor notes for acute myeloid leukemias says if the leukemia occurs before or simultaneously with myeloid sarcoma, see Rule M3. Rule M3 says to abstract a single primary when a sarcoma is diagnosed simultaneously or after a leukemia of the same lineage. Refer to Appendix B. This is Appendix Table B6, acute myeloid leukemia and related precursor neoplasms from the Hematopoietic database. Step 2. Go to the Hematopoietic Coding Manual, multiple primary rules. Find the first rule that applies and stop. Per Rule M3, this is a single primary, confirmed by lineage on Table B6. The myeloid sarcoma is a manifestation of acute myeloid leukemia. Complete a single abstract. Include information concerning the myeloid sarcoma in your text. We're going to skip rules M4 to M6 because they pertain to Hodgkin and non-Hodgkin lymphoma. Rule M7. Abstract as a single primary when a more specific histology is diagnosed as an NOS only when the Heme database multiple primaries calculator confirms they are the same primary. So example of Rule M7. In 2023, patient is diagnosed with myelodysplastic syndrome 9989/3, which is a NOS or not otherwise specified diagnosis. In 2024, the patient is diagnosed with myelodysplastic neoplasm with multilineage dysplasia 9985/3. This is a more specific histology. So in the multiple primaries calculator, the histology or morphology code from 2023 9989/3 is entered in code 1. The histology code from 2024 9985/3 is entered in code 2. The multiple primaries calculator tells me that these are the same primary. The second code is a more specific histology, and I will need to update the initial histology from 2023 to 9985/3 to reflect the more specific histology. And remember, only use the multiple primaries calculator if the rules tell you to do so. Rule M8. Abstract as a single primary and code the acute neoplasm when both a chronic and an acute neoplasm are diagnosed simultaneously or within 21 days, and there is a documentation of only one positive biopsy. Example of Rule M8. Patient presented for a bone marrow biopsy on January 12, 2024. Pathology report shows myelodysplastic syndrome. FISH shows a 5q deletion. Genetic testing shows a mutated RUNX1 gene. Oncologist states that the patient has myelodysplastic syndrome with 5q deletion and acute myelogenous leukemia with a mutated RUNX1 gene. Continuing the example of Rule M8. Step 1. Assign a provisional histology using the Heme database. The histology for myelodysplastic syndrome with 5q deletion is 9986/3. The histology for acute myeloid leukemia with a mutated RUNX1 gene is 9896/3. Step 2. Review the multiple primary rules. Rules M1 to M7 do not apply. Rule M8 says to abstract as a single primary and code the acute neoplasm when both a chronic and acute neoplasm are diagnosed simultaneously. So assign histology to 9896/3, the acute neoplasm. Rule M9. Abstract a single primary and code the later diagnosis when both a chronic and acute neoplasm are diagnosed simultaneously or within 21 days, and there is no available documentation on biopsy. Rule M10. Abstract multiple primaries when a neoplasm is originally diagnosed as a chronic neoplasm, and there is a second diagnosis of an acute neoplasm more than 21 days after the chronic diagnosis. Example of Rule M10. Patient presents for a bone marrow biopsy on January 12, 2024. Pathology shows myelodysplastic syndrome. FISH shows deletion of the long arm of chromosome 5, or 5q deletion. Patient is treated with lenalidomide. Patient presents for a second bone marrow biopsy on July 23, 2024. Pathology report shows acute myelogenous leukemia. Genetic testing is positive for a mutated RUNX1 gene. The physician states the patient has myelodysplastic syndrome with 5q deletion and acute myelogenous leukemia with a mutated RUNX1 gene. Continuing example of Rule M10. Step 1. Assign a provisional histology using the heme database. Myelodysplastic syndrome with 5q deletion is 9986/3. Acute myelogenous leukemia with a mutated RUNX1 gene is 9896/3. Step 2. Review the multiple primary rules. Rules M1 to M9 do not apply. Rule M10. Acute more than 21 days after chronic. This is 2 primaries per Rule M10. Rule M11. Abstract multiple primaries when both a chronic and acute neoplasm are diagnosed simultaneously or within 21 days, and there is documentation of 2 biopsies, one confirming the chronic neoplasm and another confirming the acute neoplasm. The exception to this rule is when you have a plasmacytoma, 9731 or 9734, and plasma cell myeloma, 9732. Rule M11 does not apply. The presence of plasmacytoma and a diagnosis of plasma cell myeloma diagnosed at the same time is evidence of advanced disease. Abstract 1 primary, plasma cell myeloma, 9732/3. Rule M12. Abstract a single primary when a neoplasm is originally diagnosed as acute and reverts to a related chronic neoplasm more than 21 days after the acute, and there is no confirmation available that the patient has been treated for the acute neoplasm. Rule M13. Abstract multiple primaries when a neoplasm is originally diagnosed as acute and reverts to a chronic neoplasm after treatment. Rule M14. Abstract a single primary when post-transplant lymphoproliferative disorder is diagnosed simultaneously with any B-cell lymphoma, T-cell lymphoma, Hodgkin lymphoma, or plasmacytoma myeloma. Rule M15. Use the heme database multiple primaries calculator to determine the number of primaries for all cases that do not meet the criteria of rules M1 to M14. Note, if you have 2 or more histologies, do not use the multiple primaries calculator first. If you use the multiple primaries calculator instead of following the multiple primary rules, you may end up abstracting an extra case. Now we will review the myelodysplastic syndromes, and the myeloproliferative neoplasms. The initial evaluation for myelodysplastic syndrome includes a history and physical exam. They will test the complete blood count, CBC, platelets, reticulocyte count, serum EPO, serum folate and B12, thyroid stimulating hormone, and HIV if indicated. They will consider genetic testing, molecular testing, especially if the patient is less than 50 years old. They will evaluate for copper deficiency and gastric malabsorption. They will perform a peripheral blood smear and bone marrow biopsy with iron stain and cytogenetics by standard karyotyping. There are 7 types of myelodysplastic syndromes. MDS with single lineage dysplasia is a condition where there are too few red blood cells. MDS with ring sideroblasts is a condition where there are too few red blood cells and too much iron in the red blood cells. MDS with excess blasts is a condition where there are too few red blood cells and too many blasts, or immature blood cells in the bone marrow. MDS with multilineage dysplasia is a condition where there are too few of at least 2 types of blood cells. MDS with unilineage dysplasia is a condition where there are too few of one type of blood cell. MDS with 5q deletion, chromosome abnormality, is a rare form of MDS where there are too few red blood cells and the cells have a specific DNA mutation. And finally, MDS unclassifiable, a condition where the blast percentages are normal, but there's a shortage of one type of blood cell. Now we review Hodgkin lymphoma and non-Hodgkin lymphoma. These are the basics. Use imaging to determine the primary site. Imaging is also used to determine stage. Imaging is critical for lymphomas. The biopsy is confirming the diagnosis, not necessarily the primary site. Lymphomas are very different from solid tumors. It is important to know the common primary sites for the histology. Primary site information can be found in the heme database. Do not simply code the site of a lymph node biopsy. Use imaging information to determine the primary site. The biopsy site is usually the most convenient location, not necessarily the primary site. More lymphoma basics. The common metastatic sites include bone, brain, liver, lung, pleura, and distant lymph nodes. It's rare for lymphoma to occur in bone marrow only. If bone marrow is positive for lymphoma, check scans. If there are no lymph node or organ involvement, code the primary site to bone marrow. If there is a history of lymphoma and the bone marrow biopsy is positive for lymphoma, then it's probably disease progression or transformation. Hodgkin lymphoma. The most common primary site for Hodgkin lymphoma are lymph nodes. It's very rare for Hodgkin lymphoma to occur in other sites. But if you have confirmation that the only involved site is something other than lymph nodes, then code that to the primary site. If lymph nodes are involved along with other sites, the other sites are going to be metastatic. The primary difference between Hodgkin lymphoma and non-Hodgkin lymphoma is the presence of Reed-Sternberg cells in Hodgkin lymphoma. Diffuse large B-cell lymphoma is a non-Hodgkin lymphoma. It can occur anywhere in the body. It can originate in the spleen, liver, and brain. As with most lymphomas, these are metastatic sites. The abstract or notes provide more information on the different types and terminology used for lymphoma. Example of diffuse large B-cell lymphoma. Patient had a right lung core biopsy, which revealed diffuse large B-cell lymphoma. PET scan of the neck, chest, abdomen, and pelvis are all concerning for lymphoma. There are FDG-avid nodular soft tissue masses in the right middle lobe, lingula of the left lung, right pleura, and diaphragm. Step 1. Use the Hematopoietic database to assign a provisional histology. Diffuse large B-cell lymphoma is 9680/3. Step 2. Review the multiple primary rules. Stop at rule M2. Abstract a single primary when there is a single histology. Step 3. Review the primary histology rules. Module 6 does not apply. Module 7, pH25 rule, says to code the primary site to the organ when a neoplasm is present in both an organ and that organ's lymph nodes. So the primary site will be C34.9, lung NOS. Laterality will be 4 for bilateral or both lungs, and histology will be 9680/3. Example of natural killer T-cell lymphoma. The path report from a skin biopsy states consistent with NK T-cell lymphoma. Bone marrow biopsy shows NK T-cell lymphoma. Imaging study shows an infiltrative soft tissue lesion in right leg, inguinal, thoracic lymph nodes, lingula, right tonsil, and uvula. Step 1. Assign a provisional histology. NK T-cell lymphoma is 9719/3. Step 2. Review the multiple primary rules. M2 applies. Abstract a single primary when there is a single histology. Step 3. Review the primary histology rules. Modules 6, 7, and 8 do not apply. Module 9, pH30 rule applies. Use the Heme database to determine the primary site and histology when rules pH1 to pH29 do not apply. So the primary site would be C14.8, overlapping sites of the head and neck. The histology would be 9719/3, extranodal NK T-cell lymphoma. Continuing with the natural killer T-cell lymphoma. For this histology, the skin, or the right thigh, is not a preferred primary site. Primary site notes for NK T-cell lymphoma in the Heme database say that the most common sites of involvement of this type of lymphoma is the nasal cavity, nasopharynx, paranasal sinuses, and palate, with the nasal cavity being the prototypic site of involvement. Skin and bone marrow involvement factor into staging and not primary site. Imaging states soft tissue lesions in the right leg, inguinal, and thoracic lymph nodes, lingula, right tonsil, and uvula. In this case, there is head and neck involvement, which is part of the aerodigestive system. Since two parts of the head and neck are confirmed by imaging to be involved, the best primary site is C14.8, overlapping sites of the head and neck. C14.8 would be in line with the preferred primary site for this histology. Skin involvement and bone marrow are recorded at stage. Example of anaplastic large cell lymphoma, ALK negative. PET scan shows involvement of multiple lymph node regions, skin, liver, and bones. Final aspiration with core biopsy of the right inguinal region, right upper thigh skin biopsy, and bone marrow biopsy all revealed anaplastic large cell lymphoma, ALK negative. Step 1. Assign a provisional histology. Anaplastic large cell lymphoma, ALK negative, is 9715/3. Step 2. Review the multiple primary rules. Rule M2. A single histology is a single primary. Step 3. Review the primary histology rules. Rule PH22 applies. Code the primary site to lymph nodes NOS, C77.9, when a neoplasm is present in an organ and lymph nodes that are not regional for that organ, and the origin of the lymphoma cannot be determined even after consulting the physician. Example of multiple primaries. On May 3, 2024, biopsy of the spleen showed small B-cell non-Hodgkin lymphoma. On June 26, 2024, needle biopsies of a liver mass showed small B-cell non-Hodgkin lymphoma, favoring a splenic marginal zone lymphoma. On September 20, 2024, IHC or immunohistochemical stains of the spleen are positive for CD20, CD79A, CD10, and BCL2. These markers support a diagnosis of diffuse large B-cell lymphoma, germinal cell type. So step 1, assign a provisional histology. Small B-cell non-Hodgkin lymphoma, the biopsy of the spleen is 9591/3. Splenic marginal zone lymphoma, the biopsy of the liver mass is 9689/3. Diffuse large B-cell non-Hodgkin lymphoma, the positive IHC is 9680/3. Continuing the multiple primaries example. Step 2. Review the multiple primary rules. The biopsy of the spleen and biopsy of the liver are a single primary per Rule M7, which says to abstract as a single primary when a more specific histology is diagnosed after an NOS, only when the heme database multiple primaries calculator confirms they are the same primary. So code 9689/3, splenic marginal zone lymphoma. Continuing with step 2 of the multiple primaries example. The positive IHC on the spleen confirms a new primary per Rule M10, which says to abstract multiple primaries when a neoplasm is originally diagnosed as a chronic neoplasm and there's a second diagnosis of an acute neoplasm more than 21 days after the chronic diagnosis. So code 9680/3, diffuse large B-cell lymphoma. Step 3, review the primary histology rules. This patient has two different neoplasms in the spleen. Primary 1, the primary site is spleen, C42.2. Histology is 9689/3, splenic marginal zone lymphoma. The primary histology rule, PH30, states 9591/3 and 9689/3 are the same per the heme database multiple primaries calculator. Primary 2, primary site is spleen also, C42.2, and the histology is 9680/3, diffuse large B-cell lymphoma. When to use code C80.9 Unknown primary. Primary histology rule PH27 tells us to code primary site to unknown primary C80.9 when there is no evidence of neoplasm in the lymph nodes and neoplasm originated in organs without nodal involvement, and there is no information to identify the primary site, and the physician does not document the site of origin. Note 1. If lymph nodes are involved, see Rule PH22. Note 2. For Langerhans cell histiocytosis disseminated 9571/3, if there is no other information available, assign the primary site to bone, NOS C41.9. Now we will review post-transplant lymphoproliferative disease. Post-transplant lymphoproliferative disease, PTLD, previously collected as 9971/3 for the years 2010 to 2020, changed to behavior of /1 in 2021, not reportable except for CNS sites. Starting in 2025, PTLD will be reportable again as 9971/3 of any site. The applicable schemas include 790 lymphoma, excluding CLL/SLL, 795 lymphoma, CLL/SLL, 812 primary cutaneous lymphomas, excluding mycosis fungoides, 821 plasma cell myeloma, and 822 plasma cell disorders. See the Hematopoietic Manual and database for additional information on this neoplasm. The Heme database should be updated before the end of 2025. The Heme Manual is updated and posted on the SEER website. Example of post-transplant lymphoproliferative disease. Path report shows PTLD, Epstein-Barr virus positive, diffuse large B-cell lymphoma, non-germinal center. Staining supports the diagnosis of PTLD monomorphic type, EBV positive, diffuse large B-cell lymphoma, non-germinal center. This is a single primary per Rule M14, which says to abstract a single primary when post-transplant lymphoproliferative disorder is diagnosed simultaneously with any B-cell lymphoma, T-cell lymphoma, Hodgkin lymphoma, or plasmacytoma myeloma. Code the primary site per Rule PH1, which says to code the primary site to site of origin, lymph nodes, or lymph node regions, tissues, or organs. Code the histology per Rule PH1, 9680/3, which says code the histology of the accompanying lymphoma when the diagnosis of PTLD and any B-cell lymphoma. Code the post-transplant lymphoproliferative disease SSDI to 1, monomorphic, which means it is present with a specific histology, such as lymphoma, plasmacytoma, or plasma cell myeloma. These are the resources used in this presentation. This concludes this video on the hematopoietic neoplasms. If you have any questions, please contact the Missouri Cancer Registry and Research Center at one of these numbers, 573-882-7775 or 1-800-392-2829. Thank you.